If you're tired of feeling scared, confused, and dismissed by doctors who won't talk about menopause, you're going to love this episode of the Menowave Lounge. We sit down with an OBGYN who specializes in menopause. We had so many questions for her that we had to create a 3-part series to answer them. In this first episode, we're going to learn about the myths surrounding HRT, who is a candidate for it, and the risks and benefits of taking it. Tune in now and arm yourself with the knowledge and empowerment you deserve.
Welcome, everyone, to the Menowave Lounge, hot flashes and cool conversations. I'm Coach Robin, and this is Coach Marty, and our special guest today is Dr. Dovile. And we welcome you in. Thank you for being here.
Well, thank you for having me here. Pleasure to be here.
Dr. Dovile Kalvinskaite, originally from Lithuania, now works in the UK as an obstetrician gynecologist, menopause specialist, and certified lifestyle medicine physician. Also a certified high-performance coach, she offers holistic care, blending medical expertise with coaching to support women, especially through menopause challenges. Her approach, rooted in overcoming personal burnout, incorporates lifestyle medicine, alternative therapies, and modern health optimization, aiding women to thrive in midlife. Dr. Dovile has established a specialized menopause clinic in the NHS and still works part-time at the hospital. She also does lifestyle, menopause, and high-performance coaching, organizes wellness workshops, and writes articles on women's health, aiming to improve holistic well-being and empower women. Dovile, welcome so much to the Menowave Lounge. We are super excited to have you. So many women in the menopause support group, they're just starving for really good, caring menopause information. So this is really going to be a very fun show. But before we dive in and hear more about you and get into the good stuff, we always like to start these shows with what we call a Meno moment. Fun little weird things that we notice happening to us or notice ourselves changing as we go through menopause. So I'm going to start us off. This is actually one that I shared in the group because somebody did the exact same thing, but had to do with my hot rollers for my hair to curl it because I'm so busy. I rarely curl my hair anymore unless I'm jumping on a podcast. And just the other day, I was sitting at my bathroom sink and I was, brushing my teeth, and I noticed that my hot roller set was on and very, very hot. I'm like, oh, because I don't remember when I curled my hair the last time. The last time I remembered was when we spoke to you last week, and that had been like several days. So I'm thinking it's right there. I stand next to it, brush my teeth, twice a day, take my makeup off, put my makeup on. Did I just not notice it? Or did I plug it in thinking it was my electric toothbrush or my hairdryer or something else? I don't know, but wow, to have that plugged in and it doesn't shut off. So who knows? It was terrifying, but that's my Meno moment. How about you, Robin?
Well, I can very much relate to that, as I find that I have long lists of things on my plate this week. And so I guess my Meno moment is remembering when I wake up, where am I at? Because not only am I packing up my house to move, but I'm also doing overnight dog sitting in somebody else's house and then coming back. And so I walk into the house and it's just like, wow, is this my house? I'm just totally unpacking it, And I woke up this morning at my client's house thinking that I was at my house. It was just so foggy in my mind that I had to just kind of lay there a moment, look around the room and go, oh, okay. And then next week I'll be in a different house. So I'm just like, which house am I in now? It's just always amazes me that how much we can put on our plate before the stress line breaks, and then we have to take those moments. And I'm taking those moments as we go along this week just to keep me balanced, because balance is really important, especially when you're doing so much on your plate and whatever transitions that you're going through. You always got to remember to take a little break, take a breath, give your mind a chance to clear out, and then regroup. So regrouping for me is, I'm doing that on a regular basis every day right now, so I don't lose it. How about you?
I was just thinking, so I did a bit of like straightening of my hair, and I'm thinking like, did I turn off my hair straightener after hearing your story? But I don't smell any smoke, so I hope it's not a meno moment.
Always a good sign. And what's funny too is I'm looking back at things that maybe I encountered when I was younger, and I feel like it's good that I can laugh about it. We've all maybe sort of done these things at different points of time, but we can laugh about it now and be like, yep, that's just one more thing to add to it.
Yes.
Oh, Dovile, we're so excited to have you here. Why don't we start us off by telling us a little bit about your journey? How did you become interested in supporting women through this often trying time of change?
I probably will start very, very early on. So when I was, I think 10, we had our biology teacher, gather us girls and we didn't have like sex ed or any kind of specific class dedicated for that, but she gathered us to tell about the periods, how periods start, what to expect, gave some leaflets. I just fell in love with periods. Like I took all the leaflets. I came home, I read everything about it. And since then, like periods and women's body parts, hormones, I was just obsessed. I was always interested, and I always knew that I would be women's doctor. So like I never had issues deciding where I want to go to school, what to study, and even in med school, which specialty to choose. It was so clear to me. So I fell in love with periods very early on. Obviously, menopause is like when periods end. Med school, we had barely any training in menopause. It's mostly focused, pregnancy, fertility, some gynecological issues. Menopause is just like, oh, periods end, that's it.
I wish.
Yeah, I know. So I didn't really understand or realize how important that is and how it affects women's life. Even in training during obstetrics and gynecology, like residency training, probably had a couple of hours of training on menopause, like barely nothing, like just explaining what happens with the hormones. These are the main HRT options, but they cause cancer. So, it's like so many myths and it's menopause. Like, what else do they want? If they're bleeding or have some cysts or some other problems, then we'll deal with them. That kind of thing. So, and then we would have these patients come in sometimes, complaining with hot flashes and all these weird other things. And you would just think I don't know what to do with them. Like, I would just get frustrated and I would feel like really bad. I couldn't really provide any real advice or care. I didn't feel like I was educated enough. And now I would go and read a bit, and then maybe it would be a bit better for next few consultations, but then you don't see them again. We didn't have like a set up menopause clinic or anything. And my aunt started asking, I'm going through these changes, these things are happening. And it's like, what can I do? And how can, how it helped me, like what's happening with me? Then I started learning more and more. And I thought, this is ridiculous. I'm a gynecologist. It's not just pregnancy and babies and all of that. I need to learn this. There's so many women asking for help. I asked actually for my bosses, just give me a menopause clinic. Like I'll learn along the way. I just need to learn this because I just really feel bad about not being able to help. And I really got fascinated with it. And when I was able to really help and combine my not only obstetrics gynecology knowledge, but also the lifestyle part, and I started seeing beautiful results and really effective things that not only with HRT, but with lifestyle things. And then women coming back a few months later. This gave me such a huge satisfaction. There's something that works for them. And that's how I just got into this more and more and learning and attending courses. That's how I'm here. So falling in love with periods and then feeling frustrated and wanting to help my aunts.
Well, we are so glad that you do, and you are a doctor that is taking care of us in our menopause years. That is so needed, and especially you're in the UK, which we've talked to a couple doctors that are there, and there's some really big movements that are happening over there. So we're really, really glad that you're a part of it.
So imagine that you're sitting in your doctor's office and your mind is just going all over the place. There's so much confusion around menopause, around HRT. Some people say it's a game changer. Some people are afraid of it. Some people say do it. Some people say don't. So many myths. So I'm very excited to dive in and talk to you about those myths, explore the benefits of HRT, and discuss the risks and the benefits.
Why do we need HRT in our life? What are like maybe some of the risks or the benefits of it?
I think probably just taking a step back, like hormone replacement therapy. So what are we replacing? So with menopause, basically your ovaries stop working, you used all your eggs and stop producing the hormones such as estrogen, progesterone. I mean, there's still some of it left and produced by other tissues in the body to some extent, but we lose the majority of it when we use our all eggs. And it's not only estrogen and progesterone, it's also testosterone, another big hormone. This actually, we have more testosterone in our body than we have estrogen. Obviously, we have less than men, but it's still very important female hormone, so to speak, that we need. And we lose these hormones when we hit the menopause completely. But not only that, the period, the perimenopause, which is about 7 to 14 years leading up to menopause, is perimenopause, where these hormones fluctuate. Sometimes we have too much of those hormones, sometimes too little. But those changes sometimes are so chaotic. It's basically perimenopause is a zone of chaos, and menopause is like jumping off a cliff, losing those hormones. So hormone replacement therapy is basically trying to replace those hormones that we lose. It's estrogen, the progesterone, and testosterone. Hormone replacement therapy covers all of them. Then there is body identical and bioidentical HRT. That's sometimes also very confusing. So body identical HRT means that with these preparations, we get the same hormones that our body produced. It's just in the form of a patch or a gel, but we're getting the same hormones that we lost. They're not synthetic in any way. They look exactly the same like our body produced. So that's his body identical hormone. So it's estradiol and progesterone. There are synthetic hormones like conjugated equine estrogen or progestins, which are synthetic progesterone forms, which don't look exactly like our body makes it. So that would be sort of the conventional hormone replacement, part of the conventional hormone replacement therapy. But body identical is the same like our body produces. And then we have bioidentical. So the difference between body identical and bioidentical is essentially how are they regulated. So body identical hormones, they're approved by FDA, the dose is regulated, and the bioidentical compounded hormones, basically they're hormones, but they're not regulated, so we don't know what dose they have, and they're not licensed or checked. They don't have those safety checks. So when you're getting them, you don't really know what dose you're getting. So the safety is a bit off, and we don't have the same level of control like we have with body identical FDA approved preparations. So that's why I would always start with body identical HRT. Those are the most safe. They're the same like your body would produce. They have the best safety profile, best efficacy on the symptom control. Then the other HRT that is also approved and controlled with some synthetic progesterones, but the bioidentical one, there are some FDA approved forms which can be used, but most of them bioidentical compounded are not approved. So that's why they're not as safe, not well controlled, and I wouldn't go there necessarily, since we have very safe, very effective body identical FDA approved options.
Until we started talking to you, I don't think I really had ever heard of body identical versus bioidentical. I think the thinking that I had been seeing, that was like your synthetic HRTs or the older kind that were made from like horse urine, but then there were bioidentical, which were better because they were more along the line of what your body made. But it sounds like that's more body identical versus bioidentical.
Yeah, so there's lots of misconceptions, and those terms sometimes are used like synonymously, but often when we talk body identical versus bioidentical, it's sort of the same hormones that your body would produce, but one is regulated, the other was not.
I gotcha. Thank you so much for clearing that up, because that's a new one that I learned, and I think it's a very important distinction.
Yeah,
absolutely.
I completely agree. This is the first time that I've heard the difference between a bio and a body HRT. When should a lady start?
Yeah, so the HRT obviously approved indications is to help control menopause symptoms. Some people now actually discuss whether we should start HRT as a preventative care for long-term health to protect bones, heart, brain. And so there's a debate on that, which I probably would agree to some extent. Obviously, HRT is not for everyone, but we can start as early as in perimenopause when your symptoms start. And if they're not well controlled with other measures like lifestyle changes and other things that we can do, then we start the HRT. Even if you still have periods, we can start the HRT very early on in perimenopause. The best time to start HRT is in perimenopause and up to 10 years after menopause. So that's sort of the safest window, we think, because it gives you the best. So take it like this. So estrogen is best to prevent, not to treat. So if you already have heart disease, let's say you're very late in your 60s or 70s, it's not going to give the same benefits, let's say, as prevention. So the safest and the most beneficial, effective way to start it is as early as possible. So either perimenopause or first 10 years of menopause. It's not to say that you cannot start later on, but we have to assess risk factors, risk versus benefits when we start later on. So there's a bit more that we have to look into. So we definitely can start at any stage if we need to, but the safest is as early as possible.
So you said could be used for postmenopausal women as well?
Yeah. So the terminology. So perimenopause, like I said, the years leading up to menopause can be 10 years, sometimes even more to menopause. Menopause is the day when you have no periods for 12 months. That's the day of that. Postmenopause is everything after that one day. So that's the rest of your life. So
Right.
First 10 years of that is sort of considered the most safe window to start. Then first of all, we don't have much data. Like if you looked at the evidence and the research, we have millions and millions, research done on pregnancy and fertility. And just a fraction of that, probably 0.03% of that, like on menopause. Like we don't know a lot. But what we know that if you started later, so 10 years later, we don't have the same benefits for reducing the risk for cardiac disease. There are even studies showing that for some women, it might make the dementia symptoms worse or dementia progress more if we started too late. There's conflicting evidence on dementia in general, but we have to take those studies into consideration. I'm not saying it's necessarily going to do that, but there are some evidence to suggest. So we have to be careful. And we also, with age, we acquire other medical conditions, more medications, other risk factors, the weight gain and all that, so which all compounds and adds to risks. So we have to evaluate all of that before making that decision whether HRT is still beneficial or is there more risks associated with it. So it's a more careful assessment, but we still sometimes start. And if your symptoms, you're struggling so much with your symptoms, you're not able to sleep, your life quality is affected, and you're just not able to live without it. It's at the end of the day, it's women's choice, and we just make that informed decision weighing risk benefits, but we definitely should have the discussion. And also even just considering like vaginal estrogen to help improve bladder symptoms or vaginal symptoms, dryness and all that, that's safe for anyone, like even someone who had breast cancer, except for the ones who are on particular one medication for breast cancer. But so that medication is called aromatase inhibitor. So then we wouldn't give. But basically for anyone else, like 99.99% of women, vaginal estrogen is safe. And I think probably everyone should be on it. It's just the way it improves the vaginal symptoms, bladder symptoms, and keeps that area healthy and reduces risk of UTIs, which is UTIs and so urine infections. It's a huge risk factor for death and sepsis. So if we can reduce that with vaginal estrogen, so even if we're not discussing like systemic HRT, at least we should be discussing the vaginal estrogen.
That is really good to know. I have a quick question going back to when we are in perimenopause, menopause, and postmenopause. I've seen a lot of women talk about that they've gone the year and they're like, yay, I'm in menopause. And then 2 months later, they get a period. And it's like the go-to is something's really bad. You're probably going to die. Go to the doctor. Is that true? Is that always true? Is there something else that could be true?
No. Yeah. So obviously 12 months without a period, it's menopause. So any bleeding afterwards, it should be investigated. Mm-hmm. Most often it probably will be what we call dysfunctional bleed. So still hormones a bit playing off, but 10% of postmenopausal bleeds, so a year after, can be related with abnormal cells within the lining of the womb, within the endometrium. So definitely requires assessment. and at least ultrasound to check the lining of the womb. And sometimes if the lining of the womb is thickened, sometimes we do a hysteroscopy, which is a camera test where we go in and take a small biopsy. So it definitely needs to be investigated. Anything that's 1 year after no periods, you start bleeding, needs to be investigated.
Thank you.
That's that's really interesting, because I have heard that question, and I can remember in my 50s where I'd have like a little bit of spotting and then it would go away. It wasn't like a full-on period. And I think at that time I was told that it's my hormones were flux. And but you're right, you got to investigate that to find out if there's something else other than just fluctuations going on there. That is really interesting, and especially the
Vaginal estrogen.
Yes, that because we have a lot of questions. I mean, women will say that it's very painful having sex with a very dry area.
So GSM, genitourinary syndrome of menopause, is so underappreciated. So probably more than 80% of women will have these symptoms. So it's vaginal dryness, itching, soreness, uncomfortable intercourse, pain with intercourse, bladder symptoms, more urgency, more leaking, symptoms like you have UTI, like you have infection, but no one finds that infection, but you have those symptoms, like you just want to go to the loo more, like it's uncomfortable. So we have lots of estrogen receptors in the vagina, in the bladder, in all that perineal area. And when we lose that estrogen, it gets more thin, the microflora change, so the bugs change, our pH changes. So we have change in discharge, it's more dry, it arouses, it's not getting wet. And so there's lots of changes happening. The bladder, the urethra gets more thin and more irritable, and that's why you leak more. The muscles, they lose the tone, so we lose elasticity. All these changes happen, and the biggest problem is that, like with hot flashes, they settle over a few years. Mostly, for some it lasts for 20 years, but for most it settles within a few years, let's say. But with these vaginal symptoms, they progressively only get worse. And some women say, oh, I don't have any intercourse, so like I don't care, I don't mind. But then they find a boyfriend 20 years later and they cannot have intercourse, and they come and help to with my shrunken vagina. So we should start thinking about early on. And like I said, prevention is better than cure. So we have to start caring after our vaginas and bladders as early as possible. And the vaginal estrogen is one of the best ways. So systemic HRT will help for most women with vaginal symptoms as well. But for actually probably 40% is not enough. So sometimes we need to give extra vaginal estrogen. And it's very low dose. It's not absorbed systemically in any significant way. So that's why it's safe for even someone who had breast cancer in the past. And it really, really improves the elasticity, the health of the vagina, the pH, the microbes, the bladder function. And it's the actually number one best way to prevent urine infections in postmenopause. It's not like antibiotic, but it's the vaginal estrogen. And it's such a simple, cheap thing that anyone can take. And yet very few women are on it.
Well, I'm writing this down in big letters to remember to put on a note to actually ask my doctor about when I go see him next month, because I had no idea. I had no idea. I mean, I hear all those symptoms and then you hear, well, HRT will help with that.
Some women might not get enough symptom relief with the vaginal estrogen. So we have other preparations with a bit of androgen, so DHEA. So some women have a bit more of like testosterone, so very simply speaking, receptors there. So sometimes adding a bit of that different type of hormone there also is very effective. So there's things that we can do to improve. Obviously, lubricants, moisturizers, that's another big topic. That's very effective as well if used properly. So lubricants should be used with each intercourse, even if you feel wet enough, you're aroused enough, but actually it dries a lot quicker, the elasticity is different. So using lubricants is must with each intercourse. So there's lots of things we can do. And often women don't feel comfortable enough to talk about that, or we don't ask, or the appointment is so short, but it affects our life quality so significantly. And it's such a simple thing to fix. Like it has to be talked more about.
Absolutely.
Wow. And all of that, you want to always have these conversations with your doctor, and these are all things that are prescribed.
Yeah, prescription medication, and definitely first discuss with your doctor. But some say, oh, you're on HRT, so you cannot have the vaginal estrogen. Not true. Definitely not true. Like I said, the only sort of big contraindication would be if you had breast cancer and currently on treatment with aromatase inhibitor type of medication. But different type of medication like tamoxifen, you could still be on the vaginal estrogen. So obviously, if you have that, it would be a discussion with your oncologist, gynecologist. I wouldn't recommend just try and buy it a black market. Definitely discuss first with your doctors. But there are options. And like I said, your moisturizer is very effective if used correctly and frequently enough. Problem with those, they're often very expensive. That's another issue. But there's definitely things that we can help, and we don't have to wait until your vagina is shrunken. That's the bottom line.
Yeah.
Do you mind sharing with us some of the more common myths around HRT?
So I think one of the most common I hear is that you cannot start HRT in perimenopause while you still have periods. So that's definitely not true. I mean, initially when HRT was approved, it was licensed for use for women in postmenopause, but that's not true anymore in any way. If you have symptoms, then we start it as early as possible. About the risk of, HRT will cause you breast cancer. I think that's the most common one, probably, isn't it? So yeah, I don't even know where to start. So the CHI study that was in 2002, I think, created so many misinformation, fear mongering, and it was so there were mistakes in the study itself. There was misinformation, misinterpretation of data, which caused huge havoc in what happened afterwards. And what that study showed, that there was a relative increased risk of breast cancer by 20%. So we have to understand relative risk and absolute risk. So absolute risk is how many actual women had breast cancer. So there was one extra case per 1,000 women. But that one extra case meant 20% of relative risk, which sounded very scary. And it was old type of HRT, synthetic one. And also it was used in the wrong population. So it was like lots of problems with that study. But it created this fear around, it causes cancer. However, in the same study, the other group in the same study that were only on estrogen actually showed reduction in breast cancer by 20%. So the only people who had like that slight increase were the women who were on estrogen and the synthetic progesterone. And the ones that were only on estrogen actually reduced risk of breast cancer. So, what are we talking about? And women are not just their breasts.
Right.
So that's one thing we have to discuss.
That.
Yeah,
I love debunking that theory.
Yeah,
they are not just our breast.
Yeah, women are not just breasts. We have to think about bones, heart, brain, mental health, metabolic health. There's so many more things that HRT does, and so it reduces risk of heart disease by 30%, reduces risk of diabetes, reduces risk of osteoporosis, and 50% of women in postmenopause will have osteoporotic fracture, which is mostly preventable. And most of those women die within 1 year if not done anything. Like 70% will die within 1 year. So, and mental health, depression, anxiety increases so significantly with menopause. And we know that HRT is actually #1 gold standard treatment for that. It's not antidepressants, and it's a lot more effective. So we have to take into consideration all of that. And for example, suicidal thoughts are 8 times more common in postmenopause. Anxiety 2-3 times more common. So, and these are things that affect people's life quality and lifespan even. So we have to weigh those benefits and risks and talk about everything, not just breast. Obviously, so estrogen, just to say, estrogen itself does not cause breast cancer, but if you have abnormal cells, it might make it grow faster. So definitely we want to check breasts, yearly mammograms, those kind of things. So it's important to do a health check before we start to assess all those risks. So that's #1. The thing is, we know that if you get breast cancer while you're on HRT, the breast cancer is diagnosed earlier and women die less because we catch it earlier. And so mortality also is reduced if compared, you get breast cancer, but you're not on HRT. So estrogen is also anti-inflammatory, so reduces overall inflammation in the body, it improves your metabolic health and everything else. So it improves your health overall. So we have to, weigh all of that before deciding whether it's HRT is for us or not. Obviously, if you had cancer in the past, breast cancer or other sort of hormone active cancer, we definitely wouldn't take that lightly. It's official, one of the main contraindications for HRT, and we want to involve oncologists and all that. And most often we would try everything else. But even in those cases, in certain scenarios, if nothing helped and the life is miserable, we do have once in a while women who had breast cancer and still on HRT because, life is so miserable that she doesn't even want to live that life if those symptoms are not addressed and nothing else worked. So not to say that everyone who had breast cancer now has to go on HRT, definitely not, but just saying that it has to be conversation, assessing all the risks, benefits, involving all the specialties if needed. And if someone who has, let's say, increased risk of breast cancer because of family history or genetics and all that, within the first 4 to 7 years, depending on the HRT form, does not additionally increase that risk. So it's still safe for those women to try. Obviously, they already have increased risk, but HRT does not additionally increase that risk. The body identical, the one that I like the most. Yeah, so it's important to understand all these numbers, and when taking the decision, take into consideration everything, not just breasts.
That is such an interesting topic when you're talking about cancer versus post-cancer and breast cancer in women, because that has come up, HRT and breast cancer. If a woman has had cancer, breast cancer, and different things like that, is there a plant-based estrogen or more of a natural? Would you recommend the body identicals for?
No, so like I said, breast cancer is sort of one of the main contraindications, meaning we wouldn't recommend HRT for those women, except in very specific cases where, either was very specific type of cancer very early or with different receptors or, a long time ago, but we still would involve oncology and extra monitoring and all that. But at the end of the day, even someone who had cancer and we wouldn't recommend to have HRT, but they're really, really struggling with life quality, nothing else helped, no other lifestyle changes, medications, and they're really having miserable time. And they understand the risks after explaining how it can increase the recurrence of the cancer. And they still want to try. At the end of the day, it's their body. And if they accept that risk, sometimes we still give the HRT and obviously offer extra monitoring and all that. But for them, it means having a life and enjoying life versus maybe potentially having cancer come back. Not necessarily it will, but slightly increased risk, or not having life and cancer free, but you're not really living it. So if it becomes that question, sometimes we might consider starting the HRT. And to your question, more natural. So body identical is what I said. The natural, it comes from soys, but it's the same hormones, the same sort of chemical formulation that our body used to produce. So these are natural compounds, natural hormones, but they can affect the growth of the abnormal tissue if you have some left. So no, we wouldn't start lightly the HRT for women with previous breast cancer. But like I said, it still has to be a discussion. So if someone comes to me, I wouldn't say, oh, no, you had breast cancer, I'm not even discussing it with you. That would be gaslighting and dismissive, and it shouldn't be that way. We should discuss all the benefits and risks of the tissues that I mentioned, bone, heart, brain, and everything. And particularly if someone is very, very young, we have to have that conversation. And even if we decide not to go with HRT, if we think it's based on your type of cancer and how long you had it ago, it's too risky, but it's still worth having that conversation and maybe discussing at least the vaginal estrogen if she's a candidate. So we still have to have that discussion and make that informed decision. I think the biggest challenge is to find a provider who listens. Sometimes just having that conversation and validating her symptoms and validating her experience is so important. And sometimes it's just all you need is just someone to listen and understand that this is not all in your head, that all these symptoms that you think you're going crazy is actually menopause related. And sometimes just understanding that really helps to cope and manage. And you might decide HRT is actually not for you. You don't want to take those extra risks, and that's fine, and definitely would support that. But just having someone to listen to you, I think that's sometimes so important. So any consultation, when the woman comes to me, I always start not what I can offer, but just listening. I think just letting her tell her story, that's probably more effective than whatever else I say afterwards, is just being heard and being listened to.
And going back to what you said about finding a provider who will listen, these women go in and they are completely shut down. Well, no, you had cancer, HRT is out of the question. And then they walk away defeated. And that's so sad. So thank you for letting them know. I know that later in our conversation, we're going to speak more specifically about how to be an advocate for yourself when you're talking to your doctor. But just since we are talking about HRT and it's top of mind in this moment, what advice would you have for a woman that gets that just gets completely shut down, gaslighting, maybe because her doctor doesn't know, or it's too complicated to explain in the 5 minutes that they're together? What would you tell her to do?
Obviously, knowing that you're going to have this type of conversation, is you need to prepare a bit yourself, and know that many doctors, if they're not really specialized in menopause, will have some apprehension or will not have enough information. So would you like me to go in how to talk to the doctor now, or leave that?
We'll come back around to it. And
I think it's just preparing and educating yourself in advance, and just knowing that you might be met with that attitude. So being, knowing how to advocate yourself, taking a friend or someone who can support you and sometimes advocate for you, because as you probably know, in menopause, it's so easy to get overwhelmed or forget your questions, or, you're sitting in front of a professional who's authority, and then just telling you all is in your head, and sometimes just like, oh, maybe it is, like you're just being gaslit, and you only when you leave you realize. So sometimes having a friend, having support, and just preparing yourself and knowing what to ask in advance and educating on those symptoms, I think it's very important.
Being educated, educating yourself, reading about it, talking to professionals. There's so much more information now out there around menopause and menopause symptoms. And so we're trying to put out as much information as possible so that women can advocate for themselves. They can ask questions. They know that there's support out there. And it's very important. Boy, oh boy, I just love this topic. And I wish we had more time to go into it, but our time is kind of running out. Marti, what are some of your thoughts on what we've heard today?
oh my gosh, there's so many. My takeaways, asking about vaginal estrogen, I feel like is like light bulb moment in my mind for me personally, but for a lot of the problems that we see coming across in the group. So thank you for that. Also, understanding what you just said, clarifying the risks for those of us who have had cancer or are concerned about it, dispelling those. And I love that. Talk to your doctor. Everybody is different and it depends on what's going on with each woman, but it's not completely out of the question. And it definitely requires a more in-depth conversation than nope, can't have it. Because the why is so important. The what's behind that. Like I've seen in the group people going, why do I need to have a mammogram to get on HRT? Why do you even care about my breast? But this is important. This is why we need to have that. This is why and is that also, I saw a question in the group. A woman said they wanted her to stop taking her HRT before she went for a breast MRI. Is that why?
Yeah, so obviously, hormones might stimulate the breast tissue, so it might be more dense and more difficult to pick up any sort of early changes. Estrogen itself would not cause cancer or cells to turn into cancers, but if you already have something, it might increase the growth and speed up the growth. So we would want to avoid that. So obviously, the whole check is important.
Wonderful. Yes. So much good stuff. So much good stuff. And I look forward to continuing this conversation in our next episode.
Yes. Once again, thank you, Dr. Dovile. I really have enjoyed so much takeaway from this. And I think our ladies really appreciate hearing more about HRTs and the bio and the body and identicals and the differences between them. This is just such life-changing information. And we're just so glad that you're here with us sharing all this information. It's just such a life-changing conversation to have. And we're going to be talking more about these topics. We're doing this as a 3-part series with Dr. D. And it's just such a critical and important conversation for women. We've been hearing these questions being asked. And so now that we have this amazing doctor here with us, we are just going to pick her brain on so many different things. You're not going to want to miss this one.
Yes.
Thank you.
Thank you. To be continued.
Thank you so much.
Thanks for joining us today in the Menowave Lounge. If you found today's discussion insightful, you won't want to miss next week's episode. Join us as we continue our conversation with Dr. Dovile Kalvinskaite, where we'll uncover an even more powerful remedy for menopause symptoms than HRT. Plus, we'll explore strategies on how to talk to your doctor about menopause and advocate for yourself. Trust us, you won't want to miss it. Stay tuned and subscribe for more empowering conversations.